Thank you. Welcome to the meeting of the Healthcare and Wellbeing Scrutiny Committee being held today, Monday, the 25th of March, 2024. For those present in this meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. For participants in the room, please use the microphones to speak, pressing down on the right-hand button. Please speak directly towards the microphone, otherwise your contribution may not be picked up on the live stream. Please ensure that mobile phones, laptops and other devices are turned to silent. Others are permitted to film, photograph and record public meetings, providing that it does not disrupt the business of the meeting. There are no members of public at this meeting at present. Only committee members present in the meeting room may vote. We have a number of people in attendance as virtual participants. Yep. And can I request that they use the raise hand feature within the system if they wish to contribute and to introduce themselves when they're called upon. Item 1 on the agenda is apologies for absence. In terms of regular attendees, apologies have been received from Hilary Hall, who's our Corporate Director, Community Wellbeing, and Christine Price, Chief Officer of Health Watch Herefordshire. We've also received apologies from Robert Mackey, who's the Director of Finance and Interim CEO of Herefordshire and Worcestershire Health and Care NHS Trust. It's such a mouthful, isn't it? As all committee members are here, we have no substitutes and no other substitutes for those who have sent apologies. So item 3 is declarations of interest. Do any members wish to declare any interest on any agenda item? Item 4 on the agenda are the minutes of this last meeting, which was held on the 29th of January 2024. They are included in the agenda pack, pages 11 to 14. No matters of accuracy have been notified to the monitoring officer. Are you content that I sign the minutes as a true and accurate record?
Yes, Chair.
Yep, thank you very much. Okay, item 5. This is questions from members of the public, and we have no questions received. Item 6, likewise, this is for questions from members of council, and no questions have been received from councillors. Okay, so we'll move on to item 7 on the agenda, which is the big long title. Excuse me a second, I'm just going to get this down here. So it's an update of outcomes on the Care Quality Commission inspection of Herefordshire and Worcestershire Health and Care NHS Trust. Who is it? I'm not going to say it again. This report provides the Healthcare and Wellbeing Scrutiny Committee with the background and findings of the CQC inspection of that trust. It also outlines the actions taken following the well-led inspection. So without further ado, I'd like to hand over to Susan Harris, who's the Director of Strategy and Partnerships. If you could, when you speak, if you could introduce yourselves and say who you are, etc. That would be great.
So I was going to start there, if that's okay, Councillor Crockett. So good afternoon, everybody. I'm Sue Harris, the Director of Strategy and Partnerships at Herefordshire and Worcestershire Health and Care NHS Trust. And my colleagues now won't need to say that again. So over to yourself, David.
Good afternoon, I'm David Thomas. I'm the Associate Director for Primary Care and Community Mental Health Services.
Good afternoon, I'm Natalie Willits. I'm the Director of Nursing and Quality.
Good afternoon, I'm Rachel Skinner and I'm Deputy Chief Nurse at Herefordshire and Worcestershire Integrated Care Board.
So thanks for giving us the opportunity to come and talk to you this afternoon. Just to reiterate again, Rob Mackey, who was due to attend with us, is really sorry he can't be here. Unforeseen personal circumstances, but you've still got a number of us who are very, very involved in the process around the CQC inspection and the Onward Trust Improvement Plan. So we pulled together some headline slides and we've had some feedback about what we thought would be useful. So just a little bit of information around the format. We're going to start a bit with the background to the organisation and when the Herefordshire services came into the Trust, and then a little bit more about what the Trust actually provides in Herefordshire. Then we'll walk into Natalie's section and she will cover what the CQC inspection involved, the findings and then the improvement plan. So thank you. So just to say that the Worcestershire Health and Care NHS was actually formed in 2011 and it came back international policy at that time to bring different services together. So in Worcestershire, we provide both mental health and community services. Just to be explicit, that's community physical health services, so community hospitals, district nurses, sexual health, dentistry, etc. Those are provided by Wye Valley Trust down in Herefordshire. So for Herefordshire, it's very much about the mental health services. That's what we cover. However, a number of us have been around in the Trust for some time. I joined the Trust in 2012, and I was previously the Comms and Engagement Lead for what was then the Herefordshire and Worcestershire Sustainability and Transformation Partnership. So I'm trying to keep the acronyms out, but they were called STPs. They were quite topical at the time, and they were a precursor to the integrated care system that we now work in, and that came into law in 2022. So I've worked with Herefordshire Partners for many, many years now, and it's still an absolute key building block in terms of keeping those relationships strong and furthering integration where possible. So the first talk about whether the services would be remaining in Together Mental Health Trust, which was previously the provider of Herefordshire Mental Health Services, started in 2018. And this was to try and streamline the footprints. So Gloucestershire ran the Herefordshire services, and it was felt it was more appropriate at that time for a Herefordshire and Worcestershire provider, which we were, because we were in that footprint, to provide the mental health services. And Gloucester then separated out, and now they run community and mental health services just in Gloucestershire. So we actually did all of the work then. It went through various processes in terms of options appraisals, preferred ways forward, staff consultation, going out to communities. But the actual transfer date when the services formally came over to the Trust was the 1st of April 2020. And I think we'd probably all recognise that was a really challenging time. We had staff moving on to different IT systems at a point when we couldn't get out to them, when we couldn't travel, couldn't meet people. So I'd like to formally thank the Herefordshire staff for doing so well through that transition. It was really tricky. And they've just continued to do what they need to do to deliver the care across the county. So that staff cohort's around 400 staff. And some of the opportunities identified as part of the transfer was we could strengthen some smaller teams. So you had some bespoke services in Herefordshire for eating disorders or perinatal mental health, mother and baby mental health. They were small and they weren't that resilient. So we were able to put some of them so that they were across the two counties, so they could have shared management, shared admin, shared resources. And then you've got the very localised services which sit out in communities. And when I'll go through the service list in a minute, David's come today to talk a little bit more about those as needed. So as you see there, the One Herefordshire Partnership is a really critical collaboration for the Trust. I represent the Trust around that table and work very closely with Wye Valley, so your acute physical health services, Herefordshire County Council, so I know I've met a number of you before, general practice, so Taurus, and the voluntary sector, and I should have also had their Health Watch. I've worked with Christine Price for many years. Next slide, please. So I wasn't going to go into too much detail, but when people say mental health services, I don't think they often appreciate the depth and breadth and the number of services we're talking about. When I started out in mental health 30 years ago, you either worked in an inpatient setting, which was often then a long-stay hospital, or you worked in a community team. What we've seen over the last 15 years in particular is a number of new services coming on stream, and we're getting continued investment to continue to develop and expand services as we see fit. There is a mental health NHS plan which sits nationally directing a lot of this work, but we do see additional investment coming in each year. However, at the moment, it's probably not keeping up with the demand we've experienced since COVID. So it's a cradle to grave service across the county. So it's children and young people, and that is primarily specialist child and adolescent mental health services, and then we've got some services that sit out in schools, and we've got some that then do the transition. Our working age adults is everything from beds to community teams, and then we've got older adults, and again we've got both beds and teams across the county. The inpatient provision, which Natalie will cover in more detail, so if we're giving you any names and you don't necessarily know where they are, Natalie will pick that up as we move on through the presentation. So we've got inpatient services and we've got open rehabilitation. So by that we mean it is a bed base, but you're not secured in that space. So you obviously, very much as it sounds, it's about recovery and rehabilitation, often for people who have been very poorly and need that step before going back and living independently. We've got the community services, neighbourhood mental health teams, and we've got a range of new models coming into that space. That's been really different over the last couple of years. Very much working with general practice and the voluntary sector, and we also have talking therapies across the county. This is probably the piece that people aren't so cited on if you haven't necessarily been close to mental health services, but this is the kind of range of community teams we have. So we have crisis services, we have a 24/7 mental health helpline, and that is for patients and carers primarily. We've got a crisis team, we've got home treatment, which actually go and intensively support people when they're acutely unwell to enable them to stay at home. A mental health liaison service, so that supports people who might go in for physical health needs but have a mental health need. So it's about making sure they're supported whilst they're receiving that physical health intervention. The Section 136 suite, just to clarify, that's a section under the Mental Health Act which allows the police to convey people to a place of safety so they can receive a Mental Health Act assessment, and that functions out of the Herefordshire County site. The other community teams cover eating disorders, that's both for children, young people and adults, perinatal, mother and baby services. We do a lot about trying to enable people to stay in work, return to work, so vocational support, often called individual placement support. As it sounds, it's a very, very tailored service to help people back into work. We've got a range of services supporting people with dementia, so that's both in terms of the diagnosis and the onward community support. In the last couple of years, we've now seen a new service being rolled out called emotional wellbeing in schools, a massive gap in terms of CAMS, so children and adolescent mental health services, what they were providing and what the schools were seeing. So this is about helping schools get their confidence and competence up to support young people, given that most young people spend so much time in their early years in school. And then we've got complex emotional needs. So that's, again, a relatively new service that's probably growing at the moment because we're seeing an increased demand for support that actually for people with that diagnosis. And then finally, they weren't inspected, but for completeness, it's just to say that we also run the community learning disability services across Herefordshire County. So just to say a little bit about facts and figures, appreciating this is across both counties. So it's a large population of 800,000, but as we know, it's a very rural area. So obviously Herefordshire, so more than Worcestershire. So you'll see at the bottom, we're two of the largest counties in England, but possibly one of the smallest integrated care systems from a population point of view. Different challenges around ethnicity, around protected characteristics. We've obviously got an increased older population, and we've got issues around fuel poor and travel issues that impact on people's ability to access mental health services and recover and reintegrate back into their communities. Persistently now, we've always struggled around our dementia diagnosis rates, so a big push on that in the next few years. That's a key national target. I've already said about the range of community mental health services we have. So just a bit about scale, we employ over 4,500 staff, so we're a large trust in that regard. We're certainly not as large as others in the country, but we're still a significant employer. And we've got about 100 sites across the 2 counties which we operate out of. That could be everything from schools, clinics, and then we've obviously got our building space, whether that's inpatient, community hospitals, rehabilitation units, etc. So Natalie, I was now going to pass to yourself to just walk through a little bit about the CQC, their approach, and then the inspection and what we've done since.
Thanks, Sue. I'll give you a brief overview and then I'll walk you through the inspection, the findings and what we're doing about the findings from the CQC. So the CQC are the Care Quality Commission and they are the regulators of all health and social care in England. So they are to us what Ofsted are to schools is the easiest way for me to describe that. They conduct either specific assessments on set services or for what we had was called a well-led inspection. And a well-led inspection involves inspections of core services as well as how well led we are as an organisation in its entirety. Whilst the inspection happened last year, the report was made public and published in January of this year, and we were moved to a requires improvement as an overall rating. We were previously a good rating. Again, I'll go through those details in a moment. Very clearly, I'm here on behalf of the board and my executive colleagues say we take full accountability and responsibility for the findings. We've taken it incredibly serious and we own what the findings are and we're owning the actions in the improvement plan. The Integrated Care Board, very supportive and have moved a gentleman called Scott Parker, seconded over to us as an improvement director to help and facilitate our improvement plan, whilst also giving the ICB assurance of progress we're making. Following the inspection, Scott led an engagement piece of work and involved at least 700 of our staff who were individually and directly spoken to get their feedback. We also sought external advice to make sure we were gaining national expertise. 2 examples of that are the Good Governance Institute, who are the experts on risk assessment and risk management in the NHS, as well as a cultural change programme called A Kind for Life, which is a national NHS initiative. They're supporting us in relation to helping us, I'll talk about a cultural reset at various points, but reset the culture of our organisation. There's 2 elements to our improvement plan. The CQC issue what's called must-do actions, which are where we haven't fulfilled the regulation that they are inspecting us against. And then there's a much broader improvement plan that not only takes into account the CQC's finding, but also the staff findings from the engagement activity we undertook. So the actual inspection began in February of last year. And it went through to the end of June. So in February through to May, they inspected 4 core services. One was our physical health services in Worcestershire, so I won't touch on that today. The other 3 involved the services here in Herefordshire. One was a core service, which is our adult mental health inpatient wards, and that's Mortimer at Stonebow on the county. The adult mental health based place of safety and crisis services, again that's based on Stonebow site, and the adult mental health community teams, and they're spread across the county, and David can give more detail if you require on those. And then throughout June, they completed their well-led inspection, which involves talking to staff focus groups, interviewing executive directors, speaking to stakeholders and commissioners. Every CQC inspection involves 5 key questions that we're asked. So are we safe? Are we effective? Are we caring? Are we responsive? And are we well led? And under those 5 domains, they give you a rating out of 4. So there's either inadequate, requires improvement, good, or outstanding. At the end of every core inspection, we receive verbal feedback. And then at the end of the well-led inspection in June, again, we receive verbal feedback that immediately led to the development of our improvement plan. The next table shows you the detail of the findings in relation to our mental health services. The 3 lines that contain the black arrows are the ones which were inspected. Just to explain some of the ratings on the table, some of those services, as you see, won't have been inspected since 2015. So we have no control over when the CQC inspects us So there's a range of dates within that. If we start at the top line, that's the adult wards for working age adults. So that's, as I said, Mortimer at the Stonebow. But there's 3 wards also in Worcestershire that covers. That was last inspected in the summer of 2022 following concerns regarding Hillcrest in Worcestershire. And following that inspection, that whole service line was downgraded to inadequate. However, only the safe and the well-led elements were inspected at that time. Following this inspection last year, as you can see, the requires improvement line has now gone overall, which is an improvement from the inadequate. However, we remain having that one area of concern under the safe domain, which I'll come back to. Further down the table, you'll see the community-based mental health services of adults of working age, and we're really pleased with the results of that inspection and note the improvement. Again, we can talk through that specific detail. And then thirdly, the mental health crisis service and health-based place of safety was downgraded from a good to requires improvement. However, that specifically relates to some environmental issues at the Worcestershire health-based place of safety and access to children and young people specialist assessments out of hours, and that was not found to be of concern in Herefordshire, but you get the overall rating for the 2 counties. Thank you. The next table gives you an indication of our overall trust rating, so that includes every single one of our services that is a regulated activity and therefore inspected. And our overall rating, and which, as you can see, is now requires improvement. So for safe, effective and well-led, it requires improvement. We remain good in the caring and responsive domains. Okay, thank you. So areas for improvement. Following the verbal feedback and in the report, you'll see there was a question about board challenge. It was identified that board has the skills individually, however there wasn't sufficient challenge within the board environment to make sure that we were making changes at an appropriate pace. There was comments about a lack of visibility of leaders, not just from board but throughout the entire organisation, so staff would talk about wanting their leaders to be more visible. A culture reset. So we recognise that we don't have the current culture that makes all of our staff feel as welcome at work as we'd want them to. That's broader than just the equality, diversity and inclusion and specifically race, but there are specific issues around race and how we're dealing with people and supporting people in the workforce who identify being from an ethnic minority background. Concerns were raised regarding risk escalation and whether Trust Board were seeing the risks that were the most significant risks in the organisation and whether some risks were being moderated, as in the scores of those were being moderated so that they didn't get escalated at appropriate moments. Do our staff feel safe in speaking up, and do they feel assured that after speaking up that action and appropriate action will be taken? Sexual safety is a very specific risk and issue that we're looking at in relation to our mental health inpatient wards. They're all currently mixed gender wards, and there was concerns raised that we weren't managing those environments in a safe enough way to ensure people felt and experienced sexually safe care. And again, I can go into more detail about what we're doing to improve that. And then for some services, they were rated very well and got lots of positive comments, but there were some governance issues about how we monitor training records, appraisal rates and supervision rates to make sure that they are where they should be, and that, again, that's escalated through the organisation effectively. So this is an overview of the current actions that we are taking. As I mentioned earlier, we've engaged with a number of external national institutions to support us. I mentioned the Good Governance Institute, who are experts on risk assessment and risk management. They have completed a review of our risk management and assessment structures and have given some initial feedback that we're just currently working through. But the key recommendations include a need to update our training needs analysis around risk management training, that we've reviewed our risk appetite statement. So as an organisation, we're really clear about what our risk appetite is. We're reviewing and resetting the group that looks at risks across the organisation and how those scores are moderated. Bless you. And we're adopting a set of key performance indicators for the risk management process. So that's how we will know in the future whether those risk assessment and management processes are robust or not. We've engaged with an organisation called A Kind Life, which has a really good history of working with a number of NHS and non-NHS organisations who need to have a look at the culture of their organisation. That's starting with sessions to over 600 of our leaders around a cultural reset in the organisation based on the principles of civility at work. And that started in March. We'll then lead that on to broader pieces of work with larger staffing groups across the organisation. There's a national culture of care programme, which is specifically based around mental health inpatient care off the back of the Panorama Edenfield programme last year. So that's a national programme of how we improve the quality of care within our inpatient settings, and we are going to be one of the early adopters of that programme. As I mentioned earlier, there's two phases. There's the must-dos and the improvement plan, which are currently we're working through. All of the actions, whether it's from the must-do or the improvement plan, are governed by our Quality and Safety Committee, our Workforce Committee, which both report directly into Trust Board. The following two slides are an overview of, we have 6 work streams of our current improvement plan, and it's an overview of what each work stream consists of. So work stream 1 was around compassionate, inclusive culture, including the equality, diversity, inclusion and equity initiatives. So as I've mentioned, we've engaged in some training and awareness. We've got a new equality, diversity, inclusion and equity strategy that's been signed off by board this month. We've increased our freedom to speak up time in the organisation and recruiting freedom to speak up champions to support them. And we're really encouraging and engaging people to use that process to raise any concerns. We've signed up to become an anti-racist organisation, and we acknowledge it's not enough to say that we're not a racist organisation, but we need to go that step further and declare that we are an anti-racist organisation and have a fair and just culture. And we've already signed off a behaviours framework that was co-designed with staff to say what kind of expected behaviours would we see throughout the organisation. Work stream 2 is our systems, processes and structures that underpin everything we do. So this is around how we are led, so clinically led and operationally enabled. So this is around our what's called a triumvirate leadership, where clinical and operational leaders work together to make sure the quality of care is where we want it to be. And we're having a complete refresh of our integrated governance and governance processes. So again, this flow of information from ward to board is where it needs to be. Work stream 3 is around regulatory standards and accreditation. So there's a range of regulatory standards and accreditation process nationally that we can sign up to. We already do that for various of our services. For example, our ECT service at the Herefordshire site has got what's called ECTAS accredited, so we know it works towards the highest national standards it possibly can. And then finally from me, work stream 4 is around our communication, engagement and planning. This is hearing the voice of our staff, our patients and carers. And when I say carers, I mean that in the loosest term. That's anybody who's involved with a patient's care, at the heart of everything we do, making sure they're fully communicated with, co-produced, and we absolutely engage at every level. And that we're using continuous improvement, or QI, to make sure that everything we do is improved and of a certain standard. Workstream 5, I won't talk through again. That's around the risk assessment and risk management processes, as well as board development sessions, specifically looking at how we conduct ourselves as board, including that effective challenge. And finally, Workstream 6 has more recently been added. This was following feedback from staff that our corporate and administration services were saying, well, this is all helpful, but where do we fit in this picture? So this is a specific work stream to make sure their voices are absolutely heard, and that we use the systems and structures that we have for our clinical services in those corporate and admin teams as well. Thank you for your time.
Thank you, Natalie and Susan. Now, shall we open up for questions, comments or concerns? Committee members, anybody want to start? Shall I just kick off then? So first of all, I was really surprised when I saw this document at the size of it. I thought, oh my goodness, 130 whatever pages. But then as soon as you start getting into the report, you understand the complexities and the size of your trust. And that really shook me to start with. And also we recognise that Herefordshire is only a part of your trust. I think Worcestershire have the majority, which is 600,000 people in Worcestershire, I think, and we've got nearly 200,000. So, yeah, the areas are quite different, although obviously we do have many commonalities. Also looking at the report, it shines a light on those differences between Herefordshire and Worcestershire, and acknowledges that we in Herefordshire do seem to be doing better at things, and I think that's a good thing for our part of it, because at the end of the day we have to, as elected members, ensure that the residents of this county are getting what they expect and what they need with the services that are on offer. Anybody else like to? Yeah, Councillor Thomas.
Good afternoon, everybody. Looking through all the figures, one thing is I've got quite a few questions, but there's one I'm going to ask now. In your improvement, you're talking about 600 leaders for a amount of employees of 4,500. That to me is a heck of a large ratio of leaders per actual people working on the ground. And one thing is pretty obvious when you've been telling us what you do, and there's so many different things. I presume that most of these services you have to offer are statutory ones. Right, okay, because the obvious question was you were trying to be all things to all people. But obviously if it's a statutory, well, there's no choice. But do you not think that your ratio of leaders per people on the ground not rather high?
Thank you. The reason it's so high is we've included everybody in our organisation in that 600 figure who has a line management responsibility. So that means that it's a huge range of job titles, job roles, job bandings. But we identify that if you line manage people, you are in a leadership position. And to effectively line manage people, we think nobody should manage more than 20 people. So that's the standard we're trying to work towards, because that then really enables effective and visible leadership. So it does sound a lot, I appreciate that, but it is a whole range of individuals, from housekeepers through to service managers, through to my colleagues here today.
Could I just add a little bit about the statutory components as well, which you flagged? I think, as I tried to say at the beginning, there's been such a change in terms of mental health delivery. So we don't talk about physical health in quite the same way. We'd be coming here today to talk to you about, I don't know, stroke, cancer services, heart disease, whereas mental health, it's all in, but there's lots of interdependencies that sit in mental health. So when you look at all that we do, it is all regulated activity in the main we've come to talk to you about today. So they are expected services that every citizen would expect to find. So, and they come down from NHS England in terms of their mandate. So, yes, I think long gone are the days we're doing the nice to haves in the same way that I think that's true for probably yourselves in the council and other NHS organisations.
I just have to say your ratio is actually 4.3 to 1, which is, as again, I feel is rather high, but probably not.
Councillor Tillett.
Thank you, Chair. Can I just sort of wind back, even before all of this, in terms of when you took us on, if I can put it like, when you took Herefordshire on, were you aware of, or in what way were you aware of the status and the standing and the problems with the system that you inherited, shall we say, and what, if anything, had you done with areas that may or may not have been identified? Well, only if they have been identified, before we got to this report.
So I think that's going to be me, as I was around at the time. So there was a whole due diligence process, and that was supported by Deloitte. It put some initial flags in, which were more around the estate, actually, than it was about, in particular, performance challenges. The performance challenges were similar to Worcestershire, so there were some issues around things like the dementia diagnosis rate, talking therapy access, etc. The bit that I could ask David to say a little bit more about. What also happened in 2020 was we launched the community mental health transformation. So the services came over in the April, and by the October we were delivering to a new model, which meant we ended up losing some people who found that quite a difficult space to work in. So we did see quite a shift in 2020 around some of our vacancy rates, and I'll ask David to pick up about where we are with those now. So the due diligence didn't throw any red flags around performance when we undertook it. The issue then would have been the COVID impact. We then had a transformation 6 months later, and I think we've ended up losing some ground there about what we could practically do. We couldn't do boots on the ground and really get under things in quite the same way. So I think we also have to acknowledge that some of what we put in clearly hasn't delivered to what we needed to deliver against. So that's the ongoing piece really about the improvement plan, looking at recruitment and retention is a big issue for the NHS overall, but it's a particular issue in some of our services. And we know, therefore, we can focus on the workforce and we can make sure that they feel motivated, they're happy at work, we're in a much better position to improve patient care. So, David, did you want to say anything about the journey of the community mental health transformation?
If I may, thanks, Sue. It does slightly predate my arrival in post. I came in after the transformation had been initiated. I think it's worth mentioning that the mental health transformation is part of a national drive and a national move for delivery of community mental health services. So it wasn't a sort of a homegrown initiative, although obviously the trust, elected to take part as part of the vanguard, and which is, say, one of the first trusts to go through this process. And clearly, the process itself was shaped by those in the services as they went through it. But yes, like any other significant change programme, and I think just to reiterate, a change programme that was taking place during a pandemic as well, and alongside an organisational merger. I think my experience of change over the years is you do inevitably get an uptick in workforce churn as a result of things just evolving. It's a moment in time when people take stock, think about whether they want to stay where they are, whether they want to go somewhere else, and so I think almost inevitably one sees a change in the workforce over and above what one might see in normal day-to-day running. We certainly did see that, and we saw some very high levels of vacancy in some community teams over that period of time, but we pretty much returned to what I would describe as fairly normal or routine now. Now it has to be said that still includes a level of vacancy and workforce challenge, because that's something that characterises the health service nationally. now, but I know I can speak for my service delivery unit, which covers the adult mental health community services across both counties. Our current vacancy rate is around about 12%, which is not where I would like it to be, but I would say also not untypical. And generally one finds one can manage to deliver the services one wants to deliver, within that sort of envelope, if albeit not entirely as one might wish.
I just carry on my slight, not exactly retrospective, but I think it's of great interest, well, I'm sure to all of us, about how we got into this position, just as much as how we're going to get out of this position. When you talked us through this one, page 9, and quite rightly sort of said, well, particularly since that's one that's particularly relevant to Herefordshire, and talked about the fact that there was only the safety one that was rated as inadequate, and the others were amber rated, shall we say. But of course, the fact is that 3 out of the others are all showing a decline into requires improvement in terms of effective, caring, and responsive. So, are you mindful of the fact that there are services which even within the amber rating have declined, and that whilst clearly the inadequates are the ones that will always grab the headlines, quite rightly, we wouldn't want to see a situation where subsequently that arrow has continued downwards and find that that's sort of red rated next time.
Absolutely. So we're focusing on all of them. So where it's good, we want it to be outstanding. Where it's required, we want it to be good. Where it's inadequate, we want it. So you can only move up or down one. You can't jump. So those other 3 lines that have come down, as you rightly say, absolutely scrutinise that. That last inspection was in 2018. So we had a look back at where that was in 2018. And you can clearly see there's an understandable decline that we knew about. Adult inpatient mental health services have been significantly challenged, and then significantly challenged during COVID as well. So they are really experiencing the challenges of a workforce crisis. Our wards often run on almost half bank and agency, so temporary staff. Now we do lots to mitigate around that, and we do lots to make sure those staff are as regular as we possibly can, but it really does have an impact on workforce, retention, as well as the quality. So whilst we make it as good as we can see that impact. So absolutely, we are not just looking at the inadequate, and making sure that every area is improving, and it's not, we understand why and what we need to do about it.
And it's very interesting that I think all of your colleagues have talked about the impact of the pandemic on staff. I assume that it actually had a profound effect on increasing demand for mental services, from the other side of the table, so to speak.
I might bring David in as well. Actually, it varied. So we saw through the first part of the pandemic, particularly for mental health, that demand went down, and our patients and relatives, they stayed at home, and they didn't want to come into hospital settings. They really did kind of that demand reduced. The effect of that, though, was then now it's much greater than it was, and we're seeing people who, particularly who weren't maybe seen or didn't want to be seen for periods of time, who are now really unwell, who've managed to kind of keep themselves away from our eyes and ears, as it were, who we're now seeing again. Now we're back working much more face to face. So yes, demand now is much greater than it was.
Worth me just adding on, and I think we really have seen that in our children and young people's mental health services, and that's obviously a significant concern, because whatever we're getting in terms of new money, we are expanding our services, but we're not keeping pace, and we've got the workforce shortage into that situation as well. So that's the balance that all mental health trusts are trying to jiggle with at the moment.
And yeah, and I'm sure I speak for colleagues who are involved in schools or governors. Yeah, it's happening at the sharp end as well, isn't it? You know, schools are certainly finding a real knock on now in terms of the mental health of pupils. Okay,
Yeah, that's fine, absolutely fine. I wondered if David would be able to explain to committee members and also the general public who are watching this the difference between primary care and secondary care. And before we go into that, I just want to add that you couldn't have come into this change at a worse time. You know, we had the pandemic, there was a cyber attack on the service, and also Herefordshire was lucky because we had the refurbishment starting at Stonebow Unit. So, you know, adding all those three things up together, you couldn't have put a worse outlook on things, could you? But David, if you could just have a few words about primary and secondary care.
Thank you, Chair. Particularly from the point of view of the delivery of mental health services and in the community, we would typically define or separate the primary care and secondary care parts of the service into primary care. Normally would be the elements of the service that sat around or alongside our GP practices and extending into some of the, let's say, lower level mental health problems that would normally be dealt with by services like talking therapy. So mild anxiety, depression, those sorts of complaints or conditions. Secondary care would normally be the more sort of severe and enduring mental illnesses, which would require a higher level of care, perhaps lifelong care in some cases. I think it's worth saying actually that part of the mental health transformation that was mentioned before is specifically intended to start to break down some of these distinctions between primary care and secondary care, recognising that actually characterising it in that way can be quite simplistic and can actually, if that is how one structures things to reflect that distinction, there's always the danger of creating a cliff edge and sort of a crack in between those two modes of delivery where people whose needs don't neatly fit into one or other can sometimes get a little lost. And I think it's fair to say there are sort of plenty of cases of that in the past which have been in people's minds when they've been thinking about how to redefine or redesign these services. So we have gone through this transformation in part to create a greater level of integration between primary care and secondary care, working more closely with our GP colleagues, working more closely in and around the practices and with voluntary sector organisations as well. And so that we can manage the care of patients as their need may vary, which it may over time, and make sure that there's less of a danger that people can fall between the cracks.
Thank you. Councillor Bartlett.
Thank you, and thank you for the presentation, everyone. I've got kind of two lines, and I just, at the moment, Chair, if that's okay, I just want to stick with some of the stuff that's come out of the presentation before getting into the report itself. When I'm looking at our communities and patients slide, this is about the whole of stats about the whole of the Herefordshire and Worcestershire footprint of the Hereford and Worcestershire Health and Care Trust. So what I would have liked to have seen in that is a little bit more around the health trust, mental health services, because I think this is really easy to understand the size of what you're doing. But in terms of what we're doing here, mental health services are a little bit lost in that. And it would have been quite useful to see as a part of that that management that you're doing of such a huge area, how much of that is the mental health services. It's in the report how many teams there are, where they're placed, and things like that. But it would have been useful to have a slide, really. And I think, Chair, going forward, the recommendation or an action, it would be quite useful to have a pictorial guide of what mental health looks like across the county. And that's my first point, because you've got 4,500 staff. 400 or so of those were the ones that transferred from Together, and you would, in your own right, have had some mental staff. Sorry, I do apologise. Mental health staff yourself. So you were actually augmenting teams and making that part of your service stronger with more people.
We wouldn't have had people working specifically in Herefordshire. So the 400 that came were part of the 2G contract, the Together contract at the time. What we've done in the services where it's made sense to do so is we put them across the two counties, so they can share management, share administration, share clinical supervision, and that's given a capacity for some really tiny teams in Herefordshire. And I agree about the pictorial guide, and I'll take an action to come back with something that picks up that activity for Herefordshire.
Thank you. But it shows that you're trying to working to make it one more cohesive as one trust. So just going back to some of the other bits on this. So the overview of the improvement plan for this is about the mental health services. You've got on the next slide that your staff engagement about this. You managed to reach 700 staff who inputted directly. So are they 700 of the people that work in mental health? Or are they 700 of the 4,500 staff you've got as a trust?
So they were 700 across the entire organisation.
Right. But are they inputting into the CQC inspection feedback?
Absolutely, there'll be a range. So there'll be staff in there who were part of an inspection, who were interviewed as part of the inspection, but then the vast majority of our services weren't inspected during last year's inspection. So it was making sure that everybody who wanted to had an opportunity to engage and be heard. So it included anyone in the organisation.
Thank you. So when I look at this then, around about 700 from a workforce of around about 4,500. My maths isn't brilliant, but I think you've got about a 15% take up on this. But out of that 15%, you don't say how many of those were actually working within the service that's being inspected. Because when I get to the CQC findings report on page 26, it talks about 134 members of staff. So I'm finding your high level statistics and bullet points quite interesting, but I'm not actually finding them directly relevant as much as I hope they would be to the CQC improvement plan in terms of the people that were reached. Because, and this is my next question, it's about going through the report. It talks about learning from improved staff wellbeing through a main question every week or every month or whatever? You're asking people to feedback on a question, according to the CQQ report. But you're also saying that you're not getting as much feedback as you wanted to, unless I'm putting words in your mouth, from reading the CQC report. So the levels of feedback are still reasonably low. So if you've got an improvement plan that is one of the measures you're showing as success is the fact that it's based on the feedback you're getting to your questions, but you're not getting very much feedback. How confident are you that you're actually getting the information that you need to address these problems particularly around inclusion and diversity, if people are still worried to come forward? Talks about whether their staff records or people not actually wanting to fill in that non-compulsory, background information that we all find really, really useful to let us know what our workforces look like. And so I'm just wondering, how confident are you that your approach to this improvement plan is strong enough in staff engagement?
I'll start, then I'll hand over to Sue. So it's multifactorial, I think, is the first phrase I'd use. So absolutely, we've got the direct feedback from the CQC inspection, which included the voices of some of our staff. We then did the engagement with over 700 staff within the organisation, which, as you said, was broader than the staffing group that were included in the inspection. We have an annual staff survey. The response rate isn't where we want it, but it does contain really valuable information. So about 40% of our staff respond to the National Staff Survey. We've also included and developed something called a pulse survey, which takes 5 minutes every other month, which asks key questions from both the CQC inspection but from the staff survey, so that we can have those moments in time where we can check on progress. That will take some time, because obviously we need to run that pulse survey for a number of months before we'll know whether or not we're getting any improvement on staff reporting how they feel at work. We also use our staff networks. So we have, and they continue to use the acronym BAME, but I'd try and use staff who identify from an ethnic minority. So we have a network specifically for our BAME staff, and we're really working with them to see if staff will feel safe talking to that network when maybe they don't feel safe talking to a staff survey or, for example, our Freedom to Speak Up Guardian. It's really important that we have so many different layers of being able to engage with staff to make sure we hear as many voices as possible, and that's why it seems quite complex, because it really is, to make sure that everyone gets an opportunity to feel heard.
Yes, I suppose just to add to what Natalie's just said, obviously we had the initial feedback as a board when CQC inspected us back in June. There were some hard truths in there about pace, the outcomes and what we needed to do differently. So we recognised at that point that CQC were giving us the voice from a number of staff they'd spoken to, but because so many of our services hadn't been inspected, that's why Scott came over really as the improvement director with a level of independence from the organisation to just go out and hear the voices of people who hadn't yet had an opportunity to contribute. It was, the resonance was there. So the things that the CQC told us were things that were echoed out in the broader staff group. So it's not a point where we've gone 700 to stop. It's 700 then we know we need to get on with this. There are particular things that our staff wanted to see us action and do as a board. So with the mechanisms like the pulse survey that Natalie's talked about, we also have a monthly Let's Talk, which can be on any topic. We did one on the CQC, and we had, getting sort of 300-400 people now coming to those events, and that's really embedding. And then we're all out asking questions about, does this feel authentic? Is it feeling different? What do you want to see? Because it was really clear that there was some actions that needed to be undertaken so that people could genuinely see that this was about trying to move us forward in a positive way. I think we've also got a group of people who came in as line managers through COVID who possibly didn't get the training and the skills development that they might have done otherwise. And we know as well, one of the biggest parts of staff engagement is your line manager. So we're putting that in as well to make sure that we've got that ongoing conversation, and then we've got this way of almost doing a temperature check every month. Is this going in the right direction? We've got some very successful comms. I mean, so the Chief Exec Weekly Brief is the ones that everybody goes to, really. So we've been talking about it all of the time. So the 700, there's people coming back to Natalie, to Sarah, the Chief Exec, and that's been happening throughout. So yeah, multifactorial but iterative, and anything that people hear about mental health services and the links we've got with Healthwatch, that's another key part of the intelligence loop for us. And are we doing the right things, and are we starting to get into a place where we're making a difference?
Thank you. Are you okay for me to carry on, Chair? That sounds like a really, really positive answer. Because I know not only were you changing and taking on from Together, but then we were changing from the STP to the ICS, the Integrated Care Strategy. Now we've got the Integrated Care Board, and so a lot of that people strategy would have sat at that level as well. So they're trying to pull everything together. And I just wondered, in my mind, I was just thinking, well, everybody's trying to make everything work, and everybody's got a kind of strategy now. We know we've got a people workforce strategy. And you were talking about some of that cultural change where people couldn't, that transformation plan that was coming from top down from the government, people were trying to manage being in a new trust and being told to work slightly differently, and then you're coming into a global pandemic. I can see how difficult it is. But on terms of that cultural idea of sort of it, they've got a fantastic phrase for it. What is it about culture? It's not negative culture. It's
Is it culture eats strategy for breakfast?
No. I'll come back to this question because I'll find it. But I'll let somebody else have a go.
Are you meaning the closed culture phrase?
Sorry?
Are you meaning the closed culture phrase?
Closed culture. That's it. Yes. So you've got closed culture, which is one of the things that the ICS have found, that within that cultural change, it's been making it more difficult for people to come forward, etc. And I was just wondering how again are you satisfied that that's now becoming an open culture, so that people who are in teams feel that they are part of that team and they are on an equal basis can now come forward and say what they want, whether it's whistleblowing or it's an idea to make it better or whatever.
Thank you. And I think I'd separate it out into two slightly different nuances for closed culture. So when we're talking about the CQC, they have a very specific meaning about closed culture. So that's in relation to institutions which are often inpatient, where you, as a patient, have your rights removed. So you're often detained, you're often there for a long period of time. Often staff work there for long periods of time. They might be isolated. And that's a very specific set of circumstances that we know are at risk, where patients' rights may not be upheld as they would be elsewhere. So for those of you who remember the Panorama Edenfield programme, that was specifically exactly an example of a closed culture. So we use the CQC closed culture guidance to really map and check ourselves against our services to identify those who are at risk of a closed culture, and then work with the leadership team around the CQC checklist. So again, we're really scrutinising whether that's a possibility within our organisation. But as you absolutely rightly said, closed culture means something different throughout the report in relation to that we don't have an open culture where staff feel able to speak out and then, as importantly, feel listened to and that something has occurred from them speaking out. And I would say that we're at the very beginning of that in relation to our Freedom to Speak Up Guardian, her full-time role, recruiting 20 champions across the organisation. We've got some initial feedback, but it's too early at this moment, I think, for us to know how successful that is being. And that's one of the questions that we're asking in the Pulse survey, so that we will get that check on a regular basis as to whether or not that's having the impact that we want it to be.
Thank you. Thank you again, Natalie. Before we go to, I was going to ask if Rachel wanted to have a word, because obviously you work closely with Natalie, and I just wondered if you'd like to say a few words on the same theme there. But in my head, I'm still thinking about who is the responsible officer for your trust. Would that be to who's leading the improvement? Is that
so if
Scott?
you're looking at overall accountability, that would normally reside with your Chief Executive Officer and the Chair, so
All right.
Sarah Dugan and Mark Yates respectively. Sarah is actually retiring on the 14th of April, and the Director of Finance, Rob Mackey, who was due to be here this afternoon, will be taking on the interim CEO role when Sarah departs. From an improvement plan point of view, it actually reports into quality and safety, so very much Natalie's been one of the lead execs. Scott has come in to give the system some assurance and to give us some much needed capacity and expertise. So, the ultimate accountability would go to the board, would go to the CEO and chair, but a number of us have got a work stream, as we showed you earlier. So, for example, I'm the communication, engagement and planning. There's a senior responsible officer, so I should be held to account for making sure my elements of that work stream contribute to the overall plan.
Lovely, thank you. Yeah.
Before we go on to Rachel.
Yeah.
I just want to pick something up that Sue said in reply, the question before last, which was that obviously when you were presented with the report, it was an experience, but that particularly in light of the pandemic, some of the things were things that were almost to be expected, or you expected. But were there things in the report that you didn't expect?
And I'll ask Natalie as well to contribute towards that. I think it was possibly the scale. So some of it, as you say, you listened, and I thought, yeah, I can recognise that. I really can. But actually, that level of concern out with the workforce about us really listening and the board being cited on key issues, I think that was a more severe end than perhaps we would have assessed it as being pre the CQC. I think for an organisation like ourselves, the Equality, Diversity, Inclusion and Equity agenda is also a learning journey. Hence why we've got in some of these expert outside organisations, because as a leadership team, we don't want to not be curious. We have a lot to learn in this space, as it clearly showed us. So that's part of the journey around the board development, the senior leadership training. But a lot of the issues were known. Were we doing everything quickly enough? So we'd put actions in, but the outcomes weren't delivering in a timely way for our staff and therefore our patients. So that's the other piece, is how do we get more agile, better decision making early? How do we get patient, carer and staff voice into that decision making? So is there anything you'd like to add personally, Natalie?
Thanks, Sue. I guess me slightly different position. So I was what they'd probably call fresh eyes. So I joined the organisation on the 1st of April 2022. And again, as Sue said, I think the breadth of the concern was the surprise, not the areas of concern. And I think it's the ability to have that time and focus on those areas when you're trying to come out of a pandemic, when you're trying to manage repeated workforce strikes, when you're dealing with a national cyber attack on your care records. And it's that, for me, it's the ability to really focus when you've got those complexities challenging everybody. So I absolutely agree with Sue. I think uncomfortable reading, but fair and just.
Okay, Rachel, would you like to say something?
Thank you. So first, it's probably helpful to give a little bit of context as to why I'm sat here with the Trust responding to this question today. So the Integrated Care Board, of course, has a responsibility for commissioning, and that is planning and overseeing delivery of good quality health services across the area of the ICB, and for working with providers of health services for overseeing and enabling continuous improvement. So the ICB has both a vested interest, but also is a really key partner in responding to the CQC report. That's one of the reasons why a really early decision was made to support the Trust with some additional capacity, but also being involved in informing the improvement plan, because we also would want assurance that the right things were included in the plan, that the right metrics were being monitored to ensure that progress is really meaningfully being made. And then part of my role in the ICB and working alongside the Trust is to sit in with colleagues, the Trust Quality and Safety Committee, which is where progress with the plan is really reported. So that's the context for why I'm here today. It's really good question around, are we collectively assured that the right number of staff are providing feedback so that we know that the improvement plan is focused on the right things. And as both Natalie and Sue have said, I think it's the beginning of a journey.
Yeah, and please forgive me, I forgot the fourth item of that massive programme change was when the ICB was formed and the CCGs were disbanded. So, yeah, there were four massive big changes, weren't there? Councillor Bartlett and then Councillor Davis.
Does Councillor Davis want to go first, seeing as I seem to have been hogging it a bit at the moment?
Yes, please, thank you.
Thank you, Chair. Thank you for the presentations. A question on the CQC inspection on the mental health services. Looking at the data we had, you've had 4 inspections, 2015, 2018, 2020 and last year. Do you think that, first of all, you think that the inspections have remained consistent in what the CQC have been looking at in their requirements of what you should be providing? So have things changed because society has changed and things been developed, and therefore not necessarily wrong footing you, but you might be slightly behind the curve because of changes to staffing and requirements?
That's a really interesting question. So what they assess us against hasn't changed, although it is about to change. So they have used the same set of regulation and regulatory standards, and they've used the 5 key domains that I described earlier, with what's called a set of key lines of inquiry underneath that. But we're talking there was something like 350 key lines of inquiry, so they're significant amount of data that they collect. So the way they've operated has changed slightly, and I think the noticeable impact has been changing how they're going to inspect from this year. So previous to that, I'd say they've been as consistent as they can be. Sometimes some of the inconsistency comes around whether the CQC have enough specialist inspectors to make sure that the inspection is completed by a specialist in the area they're inspecting, which influences obviously their knowledge base to inspect from. But now we're entering a period of significant change with the CQC. So whilst the regulatory standards have remained the same, the way they're inspecting us against them is changing. So we've changed from a very formulaic set of documents that we have to submit every couple of months to a much more relational basis of what do we want to tell them, what do we think they need to know, as well as what do we statutorily have to report to them. And they are changing entirely the way they assess us against those 5 domains. And they'll start to inspect us as a system as well. So we'll start to get system-based inspections, which will include health and social care. So I think fair and equitable up to now. We don't really know what the future lies, and we don't know. So people keep asking them about when we're going to be next be inspected, and we don't know. So we have open doors. We ask them in regularly, particularly some of those service lines would like to be re-inspected to show and demonstrate the improvement that they've made. But we have to wait.
Thank you for that. Following on from that, do you have your own? I know you do your questionnaires to your staff, as you've already said, which are done every few months, whatever, and you ask them key questions. Do you have your own assessment strategy that you follow through, as in looking at what CQC questions are asked? Do you have a management check on your systems?
So this is one thing that we have. So I've been working on since I started with the organisation. I think what previously might have occurred was that there was that check, but it sat outside of the normal or the routine governance structures. So what we've been working on is making sure that we use that CQC framework throughout our routine governance structure so that we're always monitoring ourselves against those set standards. And that's a piece of work that we'd been undertaking, and again is part of the improvement plan to take that one step forward and use the new structure to monitor ourselves against. So that is something I think was a gap leading up to the inspection.
Okay, thank you for that.
Thank you, Councillor Davis. Councillor Bartlett.
Thank you, Chair. Thank you for indulging me. I've got, I think, it's about 4 more questions, if that's okay. And some of them are quite short. So one of the things that concerned me about this was on the local board. So this is the Herefordshire and Worcestershire board. Some of it was talking about the non-executive directors sort of not really engaging as much as they could do in being very proactive on chasing down into what was going on and looking for ways of improving it. So reassurance, please, that NEDs are getting support to fulfil their role more proactively would be good.
Yes, I think you're talking specifically there. There was around the board challenge that Natalie talked about, and there was some statements specifically identifying non-executive directors around their challenge. So as a board, that's part of the development programme. We've already had some external support on constructive challenge. It's part of the cultural work we're doing to make sure it feels safe and comfortable to speak out. There's also been a bit of a change in some of our non-executive directors since the CQC. That's actually just natural retirement and new people coming into office. So they've hit the ground running with that training. So it continues to be a focus, and we do a board effectiveness review, and that will have to be part of that and when that normally is externally assessed as well.
Brilliant, thank you. Next question was just around about service delivery. So there seems to be quite a pinch point in psychology and getting hold of psychologists. And I know recruitment and retention, and particularly recruitment, is really, really difficult. So for me, that I feel that's not just your problem anymore. And I think, because the ICB, the Integrated Care Board, what are you doing to support these guys to free up that pinch point so that your waiting lists come down, that everybody gets a better service?
Councillor, if I may just respond on the sort of the operational component of that. So the element of psychology weighting that was cited in the report specifically is really primarily a Worcestershire issue. So there's a slightly complicated historical reason why the services in Worcestershire were configured in such a way which then gave them an additional level of difficulty around managing their psychology weights. So the recovery plan is primarily focused on that. I did actually check this morning just to be absolutely sure. We've only got one patient breaching the referral to treatment timelines for psychology in Herefordshire in the community component, and again that's for a very specific reason. So that's not to say though that we don't have challenges, as you're alluding to, around workforce and recruiting and retaining, a sufficient professional workforce, and we do have vacancies in the psychology team for sure. But generally speaking, in Herefordshire, it's something that we're able to manage within those parameters.
Thank you, and that's good to hear. And it goes back to what I said at the beginning. This is such a big geographic footprint, such a wide spread of services that we really could do with a little informatic of mental health services and how they sit across the two. So the other two, I suppose, moving up in severity for me, penultimate questions around risk management. So when I'm looking at page 53 findings, a lot of the risks seem to kind of bubble up and then bubble back down to line manager type of level, when you think, hang on a minute, these should be really going a bit higher. And again, that comes back to the board being able to be cited on those risks. Page 53 says it for itself, really. Some of it is pretty awful. What I wanted to look at just at the moment, though, is the risks around the estates. So the estates, you've inherited some pretty grotty buildings in Herefordshire. That well, well, I've been to meetings at St Owen Street. It's not disabled compliant. I go up and down Etna Street and Leicester quite a lot, and you go, oh, look, another bit of it's just fallen off. So in terms of the paintwork rather than anything of major structure. So you've got some risks that have been highlighted around the estates. And again, it's been caught up in some of these risks have not been really taken onto the, maybe up to the board level that they should be. Managing an estate is inherently expensive. I mean, we're lucky that we're getting Stonebow redone, and that's really great news. But have you got the budget that you need to manage this estate, to bring it into the kind of, well, up to a Stonebow standard that you'd want people that you're treating to be in, and in your staff as well, so they're not running backwards and forwards for meetings and things like that. So something about the risks in the estates and the budget to manage it.
I think the short answer would be no. That absolutely, to have the kind of facilities you want, we don't have the finance to support that. That's why it's really important that we identify and understand the risks that we have and mitigate those where we can, but then escalate the ones that are most significant. And I think it comes back to the earlier question of how were you managing and governing what was happening in the organisation against the CQC regulations. So that's, for example, one thing that we've included now as routine is one of the regulatory standards is around premises and equipment. Rather than sitting separate in our governance structures, that's now at the heart of our governance, so that in our governance meetings, estates and facilities are physically there, and we are actually then talking about whether it's the building or whether it's the laundry provision or the food provision, that those conversations are happening where they absolutely need to be happening, and the people around the table to resolve them, or if they can't, to escalate them appropriately. And that's something that, again, early days, but I think should resolve that. And then it's trying to use our resources as best we can, acknowledging the restrictions that we have. And obviously, you know, it's a lovely county, isn't it? But we don't want to try and pull everyone into one amazing resource in the centre, because as Sue spoke earlier, you know, we have issues, don't we, about fuel poverty, difficulties in getting to places. So we do need to keep services as close to the population as we possibly can. But that means that we then run a number of sites, which causes us, yes, much more difficulty. So it's a real balance of doing the right thing for the population and making the best use of our estates that we can. I don't know, do you want to jump in with some of the...
Thanks. Yes, Councillor, I mean, if I could add just a little bit of an operational perspective, and I absolutely agree the estate is, you know, has some significant shortcomings. There is a plan in the months ahead to address some of the issues specifically around 27A St Owen Street and their accessibility, and indeed the fact that that property is quite overburdened. There are a lot of people crammed in there at the moment. So there's a plan to decant a proportion of that workforce literally just over the other side of the street into St Owen's Chambers, freeing up some space and then reconfiguring to enhance the accessibility, particularly for some of our perinatal users and the disability access and that sort of thing. Actually, the one thing that would make a tremendous difference, speaking as an operational manager of sites like Etnam Street and also Rose Cottage in Ledbury, is if we had greater flexibility, or were afforded greater flexibility around the parking. So we're currently coming under some constraints from the local parking schemes being implemented, which actually directly bear on our staff's ability to get to work, or to do so without incurring extra costs. So I am currently corresponding about those parking schemes, but greater headroom there would make a tremendous difference to us and a tremendous difference to our staff.
Thank you. Yes, I mean, and then Etna Street impacts on the residents as well that are living there, and you guys parking there. And you're absolutely right that we do need the services close to where the people need them. That's why we need so many premises, buildings that work out of, and that's why it is such a headache to manage a large ageing estate. My last question, Chair, which is, I think this is the one that I probably shocked me more than anything, and that's the service not having a good track record on safety. And obviously, one of the things that really I found quite hard to read was around those, particularly for Mortimer, when those issues around the sexual safety and sexual incidences for the mixed wards. I mean, for me, Chair, we shouldn't be having mixed wards, particularly in this area, I think, where people are quite mobile and quite, and they're carrying their own challenges, and then they're kind of, it's never going to make staff's life easy, and it's never going to make patients feel safe. So I just, there has to be some major assurance that we're going to keep our patients safe. And please, can we just get away from these mixed wards and trying to manage remotely by a bit of CCTV or something like that, looking around the corner? Because this, I think, for me, was probably the most, I'm not going to say damning, upsetting part of the report for me to read, that we've got vulnerable people and we're not looking after them as well as we want to. So some thoughts about that would be really appreciated.
I think that exposure has come to us all, Jenny, in this report, that that should not be happening. And I could see Natalie was chomping at the bit there to get in to answer your concerns while we wait for Natalie to come in, I just don't. Did you want to say something, Councillor Dykes or Councillor Cole? No.
Other than that, when they have the feedback, do they take in consideration the patient? You ask them whether they're getting a good service, whether they're happy with it, and that's in hospital as well.
That's in hospital as well. So yes, they speak to patients as well as speak to the staff on the wards or in the teams they go out to. They have a expert by experience who works alongside the inspection team who is a patient for that particular area of service, and they'll directly speak to patients, and where consent's given they'll phone carers or family members as well to get as much feedback as they can from how is it to experience that service.
Thank you.
And I can confirm that, Councillor Cole, because I attend the Mental Health Advisory Group, as does Councillor Bartlett, and there are experts by experience there, and they are the voice of the people that you're just talking about. So thank you. Natalie, did you want to reply to Councillor Bartlett?
Yeah, thank you. And I think we all share that concern with you. That piece of the report was really, really upsetting. And it's a significant challenge again with the footprint of the two counties as to how we can enable single-gendered wards without moving people far away from their families, community, and the people who will provide their support on discharge. We have started a quality improvement project on Mortimer, though, to try and address that using the current ward footprint. So now we have single gender corridors. So whilst it's still under one ward, we're managing it as 2 10-bedded miniature wards under the same ward. So we have separate staffing, separate corridors, and the genders are separated almost entirely, other than some activities where they can come together. That's alongside a significant piece of work around staff training, developing sexual safety charters so that we're really clear from a patient and staff perspective of what we expect and what people can expect from us when they're on one of our inpatient units. So that's the short-term piece of work. And then, as I'm sure you're probably aware, we have a programme called Getting It Right First Time. It's a national framework, but that's looking at how we redesign our adult inpatient wards across Worcestershire and Herefordshire to see absolutely how we can modernise our services. And one of those absolutely key indicators for me is the provision of at least some single-gendered space. So when we assess people, if we know that you're a vulnerable person, male or female, that we have a safe space for you to be admitted to. And likewise, if you've a history of harm to other people, again, that we know that and we can put you on a ward or place you on a ward that, again, enables others around you to maintain their safety. It's absolutely key priority.
Thank you. And that's really good. Sadly, one of the things that I feel that I'm taking away from it is there isn't enough money and facilities for completely separated wards within the estate footprint that we've got.
Within Herefordshire footprint, you'd be moving people out of location, and it's that balance, isn't it? So as for example, a young mum, is it better to be admitted close to your family where you can still maintain your contact with your children, where the care team who are going to look after you as soon as you're discharged can input into the ward almost every day and maintain that contact? Is it better to be in a ward that maybe 45 minutes travel away? So it's a real balance.
Exactly, and that's why I'm saying, yes, I totally agree with you. We want our people, our residents, to be here. Obviously, Worcestershire want their residents to be in Worcestershire. And so for me, taking that away is that in Herefordshire, there is not enough money to make a bigger footprint to do everything that we want. And that's, I guess, is the reality of the NHS at the moment. It's not just not funded in the way that it's needed. Yeah.
Thank you, Councillor Bartlett. You did mention, obviously, funding, and I was just wondering, have you had to divert any funding from other work or services to your improvement plan? And Jenny already mentioned the estates, the state of the estates. You know, we've never got enough money for everything. So have you had to divert any funding?
So the improvement plan, we've got some non-recurrent costs that we've talked about. So some of that relates to the Good Governance Institute and A Kind Life. We've made provisions from that within corporate services, so it's not affected any investment to frontline care or the estate strategy. The big piece really, though, is we've all got to see this as our priority for the next 12 to 18 months. So it's more about making sure that whatever we've got in our business plans, this is first and foremost. So there's been some upfront non-recurrent resource made available. We're really lucky that obviously Scott's come over as extra capacity on secondment, and then it's actually how our budget's now going to factor this work in over the next 12 to 18 months, because we'd be spending money in this area where we haven't been as effective as we want to be. So it's now about a different focus. That's very much my work stream. You know, every single service delivery unit has a annual plan, and then this year you will see all of them having that work on culture, leadership, strengthening governance, etc., etc. So it becomes mainstream and business as usual.
And I think that really highlights the importance of this improvement plan, the severity of it, and your acknowledgement of the importance. So yes, thank you. Somebody mentioned right place, right time, and yes, definitely we need to get that right, don't we? I was just thinking, what services do we have in Herefordshire that we could support with possibly Talk Community? You know, we have in Herefordshire 1 city, 5 market towns, 137 parishes, and Talk Community is the signposting service that we use out in communities, and I think there are 75 hubs at the moment, and I just wondered whether you should connect with them, or do you connect with them so that you could take out your services to those communities to find out what they want and how you can help them, or they can help you?
I was saying I think both David and I have been involved both strategically and operationally with Talk Communities, the One Herefordshire Partnership, and we have got the Herefordshire Mind link workers in our neighbourhood mental health teams. So our David's actually part of the operational integrated team for Herefordshire, so or you were. So if I could pass to you for sort of some of the work you've done.
Yeah, thanks, Sue. I mean, it's a very active area of our work and our conversation. So I spoke before about the ethos that underpins the mental health transformation, about dissolving those barriers between secondary care and primary care. Also at the sort of the primary care end of that, there's very much an intention that we work together collectively to create something that's greater than the sum of its parts. So that is, as Sue says, working with with our Mind colleagues who are the voluntary sector, integrated voluntary sector offer within the mental health transformation model, which is really quite an extraordinary innovation. I was reflecting on this just the other day, just how routine now and normalised it is that they are part of our multidisciplinary team within really within the trust effectively, which is an enormous turnaround from the NHS of yore, when things very much were in a blue stovepipe and nothing else typically entered in. So but I mean, that's mine, but we do actively reach out across the primary care networks, integrating with Talk Communities and various other individuals working in the primary care settings, all of the health coaches and people who are involved in signposting to all sorts of other non-statutory and associated providers. So it's going to be something we're going to be working on, I would imagine, for as long as we're having these sorts of conversations, because it's constantly evolving. There are always opportunities to improve, but it's something we work we work on very closely together.
Yeah, thank you. And I'm sure this committee would applaud that. And if there's anything we can do to help in that area, we would do. Councillor Davis, did you want to come back with something?
Yes, please. I just had one, because we were talking costs to the business, and I was just wondering whether or not the underlying cost of using bank and agency staff is being looked at as far as reducing it and having a plan to bring it into some kind of level. And I totally understand that bank staff sometimes they're a key element of any support business, because you've got to have staff there. And if there's a pandemic and suddenly half the staff go off with COVID, then you've got to be able to replace them at short notice, and therefore that expense is anticipated per se. But then the agency staff is an additional cost on top of that. So I was wondering if there was a plan to reduce that.
There is. We have a significant project looking at how we reduce agency spend, and it's focused on agency. We have an internal temporary staff for bank staff run by NHS professionals, which, as you said, offers great flexibility for staff who maybe don't want to work on a substantive contract with us, and enables us flexibility when we have things like increased clinical activity in an area that we can flex, and then we have our own internal staff to meet that need. And that's an expense that's that's worth it because of the regular care they give you. The agency staff, as you said, is the far more expensive use of resource, and we have a whole project board looking at how we reduce that by issues such as how we improve our recruitment and our retention. So a lot of the time it's fulfilling vacancies that we can't fill any other way, and how we look at our clinical activity, and if there's other models of care that enables us to deal with that activity in a different way other than requiring additional high-cost agency staff. The other thing we're doing to make sure we minimise the impact of those is we're working with a number of agencies to look at not only cost but quality. So making sure that we are using those agency staff as appropriately as we can, and that they are treated as the same as trust staff. So they have the same induction, they have the same training, they work to the same standards that we do. So it's that very expensive resource, but it's also delivering quality of care. But yes, so we've been successful in the last 12 months to significantly reduce agency spend, but we have another plan for this financial year to further reduce that.
And you did touch on training there, and I noted that one of the required improvement areas in the CQC report for the community-based mental health services was about mandatory training, and the levels of that in Herefordshire and Worcestershire. Again, Herefordshire seemed to be on the better end of that spectrum, although, I, as a previous clinical practitioner, find it hard to understand why people don't do their mandatory training. I was held to account every year in my annual review, have you done X, Y, Z? Yes, you have. So I think that's an easy win, I think, or should be able to be. Any further questions or comments? Councillor Tillett.
Thank you, Chair. Slightly to go back to where we were on operational matters, and I think both the Chair and Councillor Bartlett and you all shared the disappointment, sadness, distress really at the whole safety element. And I think I certainly approached this report in terms of some of the operational findings, in terms of how I would feel if I had a member of family in the service, and clearly that safety analysis was probably the most worrying and would be the most upsetting. And and I'm conscious that there may be people who are in exactly that position who are watching us now, with friends and family involved. And the other thing that sort of leapt out in the same way was were descriptions of wards or areas not being well equipped, not being well furnished, not being fit for purpose. Again, which kind of jump out particularly if you're immediately involved with the service. I'm assuming that your response to those concerns are rather wrapped up in the similar reply that you gave to Councillor Bartlett about the general problem with the estate.
Absolutely, and making sure that we have appropriate methods of monitoring those estates and the equipment and the items that are within the estate. So again, very quickly we set up a different process which led to the matrons for our inpatient wards meeting monthly with the relevant estates manager for the areas that they covered to try and bridge this gap of I've reported, you know, I've done a walk around and I've done an audit of my wards. These are the areas that I've reported, but now they have that monthly meeting so that they can both be assured that everything's reported, but also being acted upon. And we've developed a new estates and facilities tracking system so that staff, when they report an issue with an item, can see that what's happening with that, because that's what staff would say is that I don't know what's happened to this. I've reported this as broken, but nothing seems to have happened. So whereas now they can see what is happening with that item. And again, if they log on and can't find it, they know they need to report it as it hasn't been previously done so. So a number of actions that we've taken to improve that.
That's good to hear, and I'm sure fellow councillors will recognise the problem of reporting problems and not having any idea about what or when anything is going to ever happen, with all sorts of individual bits of casework that we face on a daily basis. Now to go to the other extreme for what is going to be my final question, I think, Chair. What sort of timescales are we looking at for these changes? You know, when and it's important for us not only to know as a principle, but I think on a practical point of view, because obviously I think we would want to meet with you again in the future and find out about how some of this is going. And so, you know, what sort of timescales have you set?
If I just say, I think first of all it's to recognise that some of this is a longer term journey. So things like culture and that leadership development and training, we've started that already. So the Kind Live sessions started last week. I personally went on a couple of them, very well attended. They said that was the best attendance, i.e. no limited dropout that they've experienced in a long time. So that one, you know, longer, and we put in measures where we want to get that real-time staff feedback. But most importantly as well, is it then translating to how patients and carers experience our care? So we've got some measures in there. You could be talking, you know, 6 months before you sort of get into something that might translate to 12, 18 months. That will be the whole cultural piece. Some of the other pieces, which I'll ask Natalie to pick up on, is things like bringing in that estates into the integrated governance. That's already happened too, and the kind of wiring around risk, we're actually on that journey at the moment and making those changes now. So we've got a very detailed improvement plan which we have a monthly programme board around, so all of the work streams leads come into that space, and we've set our own trajectories and we're holding each other for account for those. There's a lot of interdependencies that we need to keep sight on as well. But in terms of quality and safety, that receives the report every couple of months as well, doesn't it?
Yes, I guess reaffirm what Sue said. Some of them were instant. So particularly when you're looking at the CQC, the must-dos, where we haven't met a basic standard, they are an instant action to put something in place to resolve that with immediate effect and then monitor it over the next 12 months. So we put a significant number of pieces of work in last summer as soon as we got the verbal feedback. So some of that is already enacted. Perversely, you might see some what looks like deterioration. So for example, if we go back to sexual safety, now we've been crystal clear of what is accepted and what isn't accepted. What we've seen is an increase in incident reporting. I'm heartened by that and I'm reassured by that, because now I've got real confidence that staff are identifying when an incident is a sexual safety incident and what is not acceptable behaviour and are reporting it. But obviously that then looks like we are now reporting more incidents. So some things might look like they're worse, and actually we then need to understand what that looks like. And I think it's to reinforce, you said the phrase earlier about culture and strategy. The cultural changes will take time to embed, and for the monitoring of those for us to know whether they're being effective. So cultural change does take a year or two to make that sustained improvement. And the CQC, so I meet with them regularly still, and they were really clear that actually we know cultural change takes time, so we don't expect to see your culture to change instantly. We expect that to see sustained improvement over several years, and that's when we know you've got genuine change that's embedded.
Are you confident that your measures to monitor these changes are robust enough, regular enough, and will make sure that you know that you're heading in the right direction?
We've still got some improvements in the data that we collect that we're working through. So we have a basic set of metrics, and we have people like David who work very hard to pull together performance data and other metrics to supplement that. What we've developed is a new suite of metrics that I think will be far more helpful and sustainable longer term. But that means our performance team are having to look at the data we have and reorganise it very differently. So I think we know what we need, and we know what we need to do to get us there, but it's not currently in place. But we have different metrics to help in the short term.
And probably just to add to that, some of this isn't the what, it's the how. So we have developed the behaviours for all with our staff. Now that'll be, does it feel like it? Does it feel like that at work, that you can bring your whole self to work, that you don't feel that you can't contribute, or that you're experiencing discrimination? So some of that will run through the pulse survey. Will the measures be absolutely right? We may not know, but we know we've got to start somewhere and be asking the questions and listening and learning. And likewise, I've been doing some work with Healthwatch in Herefordshire about them. What would those behaviours mean if we got them right in the organisation in terms of patient and carer experience? So did you feel listened to? Were you involved in that conversation? Did it feel like you were welcome when you walked in from the reception staff? It's that sort of nuance. So we've got some hard and fast measures, and we're building those in, and then we're co-producing some of the others, because I think that's also part of the journey about agreeing how we want to work together.
Thanks, Sue. Okay. So before I bring Councillor Gandy in, and also Matt Pearce is virtual attendee, I just wondered if we had any urgent recommendations to add before we move on. Nothing else to add?
Well, sorry. Well, I was just going to suggest a recommendation to request the Cabinet just to look at a quite very, well, no, not quite very specific, that doesn't make sense, does it? An extremely specific point that you made about the difficulty of parking for staff at certain sites. And the parking controls therein. I think you talked about St Owen Street. Is it Rose Cottage in Ledbury and Etnam Street in Ledbury? In Leominster, I beg your pardon.
Etnam Street and Rose Cottage.
Rose Cottage, yeah, and St Owen Street, just to see if there is any. Well, at least that there should be at least a bit of a conversation between you and the Cabinet, just to see if there's any leeway. I know it's very difficult, and Councillor Gandy's not looking very optimistic at the moment, but just, this is a specific problem, raised in a CQC report, and I think if we can't at least make a recommendation that it is just at least looked at, to see if there is something practical that we as a council can do, then I think we should make that recommendation.
Thank you, Councillor Tillett. Over to you, Councillor Gandy.
Thank you. First of all, I want to thank the Herefordshire and Worcestershire Health and Care NHS Trust for this presentation, and also to thank the members of the committee for what were some very useful, penetrating questions that were being asked this afternoon. Having read the report myself, I think we all recognise within our own organisation how difficult it is when you receive a report that is so take such a difficult read. There are some positives in there, and you need to obviously remember those. But obviously everyone will concentrate on the more negative things. I think for me the main issues are the mixed wards, and I recognise the issue around the cost and what I just wondered whether this has ever been picked up before in a CQC inspection, because obviously this has been going on for infinitum, so I don't know why it's just suddenly been picked up now.
It hasn't been picked up before. It's a good question as to why it wasn't picked up before, and the CQC actually don't have a set opinion on mixed gender wards. So the mixed gender wards isn't the issue for the CQC. It was how we were managing the mixed genders within that environment that was the concern.
Okay, but from a portfolio point of view, holder point of view, I personally would not support mixed gender wards per se. I just do not think that is the way that we should be continuing. But I do recognise that from the trust point of view, the cost implications of this and the ability to be able to deal with this is not easy. My other concern, obviously, is regarding the issue of staff working in the trust feeling that they are being either racially not accepted or because of their protected characteristic, that's not being recognised and accepted either. And I think one of the problems with that is that when you are struggling to recruit into a service, if you have a service where it is thought that this is a problem, that makes it even more difficult to recruit. I recognise that changing the culture of an organisation, whether it be within the NHS or within Herefordshire Council or any other public organisation, is a really difficult thing, because ultimately what you're trying to do is to change people's perceptions, and changing people's perceptions is actually something that is almost is impossible. So I can understand that you think this is going to take 18 months to 2 years, but whether you can actually change the individual's perception is another matter. And sometimes, rightly or wrongly, those people who cannot change their perception are not the sort of people you want working within your organisation. And that is obviously something that you, as a trust, are going to have to look at. And that is difficult when you are already having to recruit agency staff. But it's very almost impossible to actually change the culture of any organisation without there being people within that organisation. Unfortunately, you can no longer accept continuing within that situation. The rest of the report, I think, is really good. I think what you have demonstrated, you have acted on, you recognise the issues that have been raised. You've not shied away from probably any of them, which is really refreshing to hear. I think you've identified those that you can deal with immediately, and you have shown that you've rectified those. And I think you do appear to be on the right path to at least achieving some of those within the next 6 months or so. And I think that's something that's very positive. So I thank you for that. And I'm really delighted to have been here today to hear the comments made by members and the trust.
Thank you so much, Councillor Gandy. Matt, I'm sorry, I did see you pop up, but you've disappeared again. Would you like to? Here he is. Matt, thank you for tolerating us here.
Yeah, thanks, Councillor Crockett. I don't have too much to add, to be honest. I've been listening intently to all the members' best views and really value the presentation by the Trust. I think just a small thing for me is, obviously we know that mental wellbeing is one of our 2 priorities in our health and wellbeing strategy in Herefordshire, so it's something that's really important. And that's not just come from officers and members, that's come from our communities of patients and service users. So clearly mental health is something that everyone wants to support in Herefordshire. And obviously we want those organisations to be in a suitable place to be able to do that. And secondly, I think it's just, you know, a word of positivity. I've really valued my working relationship with the trust. I think they're really engaging with that work stream and supporting us with that priority. And it looks from what they're doing, they're making some good progress against some of the shortcomings that were identified in that report. So that's all I wanted to add. Thanks.
Thank you very much. Okay. Oh, Councillor Bartlett.
Thanks. Yeah, coming full circle on this, I do feel you're going in the right direction, and I do appreciate the amount of time that you've given us today. Going back to recommendations, if I may. So we've got that action about the info tech, whatever it's called, of what mental health services look like across 2 counties, and those geographic footprints. We've also got at the back of the presentation the 6 key elements of the improvement plan, which are broken down into major headings. So my recommendation would be that at an appropriate time, these 6 key elements are fleshed out, come back, and they have some kind of journey in them. This is where we were. This is where we are now. This is what we've done, and this is what we intend to do. And I think that would be quite useful.
Hasn't worked.
Would be, yes.
We tried this, but this didn't work, so we're trying something else.
Yeah. Yes. So honest.
Yeah.
Yes. So that I think that would be my 2 recommendations. Or 1 action.
I think that would be really helpful. Obviously, there's a lot of detail sitting in the improvement plan by work stream. So obviously I know mine inside out, so could give you a history of, you know, what we've done so far around patient voice and more visibility in our governance, etc. So certainly if we were to come back at a time that the committee feels is appropriate, we could give you an update and all 6 domains.
Thank you. And just the final thing, really, Sue. When are the CQC expecting to come back? Have they given you an idea? No.
Unfortunately not. And it is wrapped up in the moving to a different assessment framework. But we've been very keenly inviting them in, particularly back to see the changes we've made directly from the report. So and we'll keep inviting them. Is all we can do.
So with this new framework, does that mean that if they don't inspect you until that new framework has happened, you will be being inspected against, in a different way, which is going to make it very difficult for anybody, least of all us, to really gauge what progress you've made, but more importantly, for you to gauge?
It will, but there's some benefits in the new structure. So actually the whole rating system's a lot clearer. You can see where you are on the trajectory a lot clearer, and they're using a much more rounded base of evidence to collect when they're looking at it's the new 34 quality statements. So actually the new framework for me, whilst it's challenging in moving from one to another, the new framework is a far better measure of us as an organisation.
Thank you very much. Okay, so no other comments from anybody, trust representatives or anyone? No? Okay. So could I ask if we've captured the recommendations? Do we need to adjourn, or have we got those clearly set out?
Hello, Chair. I've picked up 3 points here, whether the recommendations or actions remain to be determined by the committee. I have as follows. First of all, the Cabinet to consider how it can support NHS staff with parking availability and charges when undertaking locality-based working. Have I captured that?
Yeah. I don't know if we want to tighten it by being very specific. Thank you. I don't know if we want to tighten it by being very specific about those locations. I mean, Otherwise, we start to get involved. I mean, that could be taken as an open invitation to look at parking at the hospital, for instance, which is in many ways is a nightmare can of worms. And as much as we might like to open that, that's not what we're talking about. I don't know. Perhaps Dave
It might be helpful to clarify it, and I think this is the distinguishing point. For Etnam Street and Rose Cottage up until now, so Etnam Street in Leominster and Rose Cottage in Ledbury, until now we haven't had any issues because there haven't been, well, I say no issues, no, not this issue, because there haven't been parking schemes introduced there that have restricted how the staff have previously managed their attendance at work. So it's the implementation of new restrictions on the parking there that are causing us the issues.
Chair, if I could clarify, I think you're probably talking about the introduction of residents on street parking. And yes, well, I applaud what you're saying, Vice Chair, about trying to find this, but this is also going to be an impact for a lot of the local businesses as well. So as a ward member, I'd probably say, could we also tack on local business users that use Etnam Street for parking to work in town? Because, and this is the problem that the cabinet are going to have. But absolutely, I think parking and ability to get to and from work for our NHS colleagues, as well as all our other partners, is a big issue. It'd be interesting to see where it goes with such a small I thought I didn't know it was that's the benefit of not living in Ledbury or Leominster. I didn't know it was resident parking we were talking about. So yes, how do you manage knock-on unintended consequences is a very good question. So I'll just leave it there, Chair.
Yeah. I think if you're going to start making recommendations that concern a single locality, I'm not really sure that's within the remit of scrutiny anyway. So I recommend you either make a general recommendation because you've got a concern around how we support NHS staff and our own social care staff, arguably, around parking, or you don't, basically. So I think a very specific one is unwise.
I mean, I beg to differ because we are specifically scrutinising this report and specific problems that have arisen relating to this report. And, so whilst I sympathise with the whole idea of trying to support all our NHS and other care and health workers, this report specifically has flashed out a couple of new problems which have arisen in Ledbury and Leominster as a consequence, now I know, of residents parking. If you really do feel it's inappropriate, I will cede the point. But I'm just trying to respond to specifically what we are scrutinising today.
Yeah, and I can see what you mean about specifically what we're scrutinising today, because obviously that's what we've. But I think it takes a part of a wider problem out of context, because there is, as our scrutiny officer has pointed out, there is an issue across the board of supporting NHS workers and partners and in parking. I'm conflicted on this. I wouldn't support it. I'll probably abstain out of respect. But I think I would be minded to take the scrutiny officer's advice that if we wanted to, it might want to be a bit of a wider issue, a wider recommendation that would actually enable an important conversation about supporting our health partners.
I think a bit like Councillor Tillett, we're looking at this report, and if we have to address this in other areas, then we address them at those points. I think what we need to do is take a vote on it. And the recommendation is,
Well, I think there are two proposals here. There's a recommendation. I've suggested that you make a general recommendation on parking. Councillor Tillett has made a very specific recommendation. So I think first of all the committee needs to decide where it wants to go with this. Does it want to a very specific recommendation? Does it want a general recommendation, or does it just want to just not go there full stop? So. So I'd suggest first of all you vote on whether or not you want to choose one of these two suggested approaches for a recommendation.
I would actually suggest that we would do it as a do both. So you would vote on the amendment first, which is yours, scrutiny officer, that we do it as general. See where that goes, if that's got legs. If it hasn't, then we go back to the substantive one, which is the specific recommendation.
Is there perhaps not a compromise? I don't want to spend up too much time on this narrow point that I thought I was trying to be helpful here. Well, no, I still am trying to be helpful. Is there not a compromise situation where we make the general recommendation and then put "and in light of the CQC report" with specific reference to Etnam Street and the recent changes in Etnam Street and Rose Cottage, Ledbury? Would that satisfy everyone, perhaps? Possibly not, Councillor Bartlett.
No, I would go for the general recommendation. I mean, if you want to put some specific information into that, then that's absolutely fine with me. But the fact that we're going for a more general recommendation is, I find, that opens that conversation a lot. I could support that, yes.
So, pardon me. Cabinet to consider how it can support NHS staff with parking availability and charges when undertaking locality-based working, specifically with regard to locations, Ledbury
and Leominster, Rose Cottage and Etnam Street.
To Rose Cottage
Ledbury.
and Etnam Street, Leominster. I'm going to read this out again. Cabinet to consider how it can support NH staff with parking availability and charges when undertaking locality-based working, with specific regard to Rose Cottage, Ledbury, and Etnam Street, Leominster. Okay, that was the first one. There's a second one. The Trust be requested to provide an easy-to-read guide to mental health services across Herefordshire.
Well, it was actually the infotech rather than just the guide.
Pictorial guide.
Yes.
Infographic, an infographic.
Yeah.
So with an infographic-based guide. Infographic. So the Trust be requested to provide an infographic guide to mental health services across Herefordshire. And then finally, an update to the committee on the 6 work streams of the improvement plan in due course.
Are we going to tie that down to a
In due
timeline?
course is a little bit floppy.
It's not fair for anyone.
I wouldn't just put a timetable in there because obviously, as you've heard today, work like this is...
Chair, we're a third of the way through 2024 and we've got a lot of other work to do. Would we say that we would like to see this in early 2025? Would that be a general enough timescale?
Well, I wouldn't pin yourself to it. I think, as the Trust have said, this is fairly complex, multivariate work, and as you've said yourself earlier, some of this might not even be successful anyway. So I wouldn't tie yourself at this moment to looking at this. I would ask yourself in 6 months or so time the question of whether or not this is the right time to do it. I wouldn't tie yourself to a specific time on this. Otherwise, you're just filling your times up with things that that may or may not be the right time to look at them.
Chair, sorry, I don't agree because, as Kevin said, Vice Chair said, we'd quite like to know if it's not working as well.
Okay.
And I think in You'll have 9 months of this year, and then you'll have wherever you get to in early 2025, so 10, 11, maybe 12 months even. If you don't know anything by then, we are really in trouble. So I suspect, and I am confident that you would have something to bring back to us by then.
Does that seem realistic?
Yes, I'm comfortable with that. Just to confirm that Worcestershire Hospital have asked for 6 months, so it's in the knowledge that some of these pieces of work will take longer, but we can give you assurance that they're progressing, and some of them will be very much finished. So, that feels comfortable.
Meanwhile, I'm sure we'll all be watching this space anyway, so if there are any concerns, we can call it back in.
So that final recommendation will be the trust to return to the committee to provide. Sorry, bear with me. I've not. Right, it will be the trust to provide the committee with an update on the 6 work streams of the improvement plan within 12 months.
Okay, so the recommendations on this report are to acknowledge the covering report, A, the committee note the report and findings, and B, have got the recommendations as directed or explained by yourself. Are we all in favour? Oh no, I'm going to propose it. So do I have a seconder? Seconder is the vice. All in favour? Yeah, unanimous. Thank you. Thank you very much. And a big thank you to all the trust members that came this morning, this afternoon even, and also the cabinet member and our public health director. Thank you very much. If you would like to leave, that's absolutely fine. So, thank you. Okay, we have a number of people leaving the meeting at the moment. We have the work programme as the final item on today's agenda. Okay, all right, okay, so can we stop the live stream for 10 minutes, please? I'd like to welcome everyone back to the meeting following that short adjournment. So we'll now carry on to item number 8, which is the work programme for 24-25. And the purpose is to consider the draft work programme for the Healthcare and Wellbeing Scrutiny Committee for the municipal year 24-25. And I'll hand over to Daniel.
Thank you, Chair. The work programme is as published in your papers. The original work programme that we agreed earlier in 2023, or late 2023, has been pushed forward or pushed back by 2 Care Quality Commission inspection reports that have been published. The first one, which we've looked at today, around the Herefordshire and Worcestershire Health and Care NHS Trust. We'll be looking at another one on the 20th of May. You're meeting there around the Wye Valley NHS Trust concerning the county hospital. This means, as a result, your work programme items for March and May have been pushed forward. So the plan at the moment is in July to be looking at supported housing for working age adults with additional needs, and also supporting care leavers. The work on that has been prepared already, so that should be a fairly straightforward item to bring to the committee. And then in September, we're looking at the West Mercia Most Appropriate Agency Policy. Notwithstanding this, of course, anyway, it's one of this committee's duties to occasionally review its work programme, how it's carried that out and what it might want to look at in the future, particularly in light of other council priorities. So in that regard, obviously the committee is meeting at the end of this meeting to do a quick review of its work programme.
Thank you very much. So the recommendation is the covering report recommends the committee agree the draft work programme, which is subject to periodical reviews as the basis of our primary focus for the municipal year. I'll propose that. Can I have a seconder? The Vice Chair seconded. And all in favour? Unanimous. Thank you very much. Okay, so the final item on the agenda is the dates of future meetings, and they are as follows. The next one is the 20th of May at 2 p.m, and then July, September, November, January next year, and March next year, as all documented in the paperwork. Okay, I'd like to thank everybody for their attendance this afternoon and ask that the live stream be discontinued at 16:28.